Obamacare provides support to people who make up to 400% of the federal poverty level. And for an individual, I think I looked it up, somebody told me yesterday, I looked up, it's close to $45,000 a year. Now, the amount of subsidy, the amount of support you get varies. It's on a sliding scale, depending on where you are, you know, between 400% and down to 139%. Why 139%? Medi-Cal covers everybody now up to 100% of the federal poverty level. Obamacare provided states with the option of expanding Medicaid as the federal program. And so in California, under Obamacare, that 100% threshold of poverty will be increased to 138%. So if you make up to 138% of the federal poverty level, you will be eligible for Medi-Cal. If you're between 139 and 400% of the federal poverty level, you will be eligible for a level of coverage, a certain level of coverage, of support, of subsidies. Next week, I'm going to bring you, or I'm going to send to you ahead of time, you'll have a guide which is going to tell you exactly what that buys, how much that is and exactly what that buys. You may get coverage between 139 and 400%, subsidized coverage. You may get that, the only way you're going to get that coverage is through the exchange. We had the federal government put together, and we're going to talk about exchanges in a moment, put together supermarkets where you can go to buy health care, which is this is my definition of an exchange. It's a supermarket. A supermarket of health plans who have agreed to do da-da-da. If you make over 400% of the federal poverty level and you're not employed, you can still go to the exchange and go to the supermarket and get care. You just don't get a subsidy. That's all. So Obamacare was taken to court. This is why I tell this story. The U.S. Supreme Court, on a very close vote with the Supreme Court Chief Justice Roberts providing the deciding vote, that Obamacare was constitutional. The challenge was that it was not, that making people buy something was not constitutional. That's why I say, can the government make you eat broccoli? You know, I'm like George Bush Sr. I don't like broccoli. There's nothing you can do to make me eat broccoli. He really got into trouble for saying that, too. But anyway, so the Supreme Court says yes, but the federal government cannot make the state expand Medicaid. So that was the big deal. We cannot make the states expand Medicaid. Now the incentive was that the federal government was going to pay 100% the first year, or 95, I forgot, but they were going to pay all of it, pay for all of the expansion. And then that expansion, then that amount was going to decrease down to 95% and whatever. So it wasn't going to cost the states any money. But politics being politics, a lot of Republican governors said they simply were not going to do it. Some of them have found religion now and changed their minds. But so it passed that test, so the Medicaid piece for expansion became a negotiation between the states and the federal government. Otherwise, that's the way the program works. So you can get your coverage through this supermarket. But before I go to the supermarket, just a real quick list here. Well, let me skip this. Just let me skip this and go straight to the supermarket. Here's the supermarket. Every state was asked, I say asked because there was no mandate. Every state was asked to put together this supermarket called a health benefits exchange so that we could do this. So people have to where to go. By the way, I forgot to mention, individuals can go to the supermarket, but so can small businesses. And small businesses for the purpose of this thing are those that employ less than 100 people. They can go. In 2018, I think it's 2018, it's either 2017 or 2018, the lid is taken off of the number of workers that a company can, so any company, Walmart could go to the exchange if it wanted to, okay? But first year, only companies fewer than 100 workers and all individuals can go. California was the first one to put up a health benefits exchange, and it's since been titled or called Covered California, and they have a website which you should become familiar with. And these are the people who serve on that board. Two of them, the two on the left, Susan Kennedy and Kimberly Belshea. Susan Kennedy was chief of staff to former Governor Schwarzenegger, and Kim Belshea was the Secretary of Health and Human Services under Schwarzenegger, and when Pete Wilson was in office, she was the Director of Health Care then. Diana Dooley is the current, so they were appointed by, those two were appointed by Schwarzenegger before he left office. The law calls for the existing secretary to automatically have a seat on this commission and to automatically be chairperson. So the Health and Welfare Agency Director is chair and automatic seat, and that is Diana Dooley, who is the current secretary under Governor Brown. And then Paul Führer from Northern California was appointed by the Assembly Speaker, and Dr. Robert Ross, the local guy here, he's the local guy, a good friend, he's the president and CEO of the California Endowment. He represents the California State Senate. So those are the 5 people who are running the show here. And this is the place, folks. This is the place where the action's going to take place. What they had, the charge that they have, and they've done it, to go out and get health plans to sign up and agree to provide coverage in the supermarket, according to certain rules. And again, next week I'll give you the greater detail on that. And then in October, they start enrolling people who are individuals who are eligible. This is where the big push comes. This kicks into, the coverage kicks into place on January 1 of 2014. Okay? That's when the coverage starts. That's when we want to try to get all these uninsured people insured, starting January of 2014. So between October, and actually it'll go beyond January because it's going to be a continuous process, but we're going to start in October trying to get people enrolled. And anyway, so that's it'll do it through this exchange. And one of the things that they'll be able to do, in addition to just getting a wealth of information off of their website, is they're going to be able to get online, they'll be able to look at the health plans, every health plan that's providing care in their service area. They'll be able to compare, look and see, look what benefits, all of that. It'll be a compare. It's like taking your kid to the supermarket and say which box of cereal you want.
Who's part of that exchange as of right now?
Who is part of it? Meaning?
The insurance company.
Oh, I'm going to give you the list next week. Unfortunately, it's not a whole lot. A lot of insurance companies have opted not to play in the exchange. So, Deborah, do you know there's some?
Well, I think it's a lot of health insurers who already have a reputation for doing the work of low-income people, like care, and well, Marina, no, they're a provider, but
Right.
it's a lot of these providers who already have a reputation going into that market.
Sure.
Just like jumped into it.
What she's saying is that a lot of the insurers who are currently providing care to that market are going to continue to do so, but not through the exchange. Yes.
What's going to happen with the big players like Blue Cross, like Blue Shield, in this scenario?
Blue Cross has agreed to be in the exchange. I'm not sure about Blue Shield. I'm going to bring you the list next week because it's going to be in that package of information that I have.
How do plans like Kaiser work with the exchange?
How do plans like Kaiser work with the exchange? Kaiser is going to be in the exchange.
Yeah.
They're going to be a player in the exchange. Remember, the health plans being offered through the exchange are commercial-like plans. So you become a Kaiser member. You'll become a Kaiser member. But you will have gotten it by virtue of being in the exchange. And if you're eligible for subsidies because you make less than 400% of the federal poverty level, then that will go towards helping to pay your premium to become a Kaiser member. Right now, Kaiser takes, and don't stick me on this number, it's around 50, 60,000 Medi-Cal patients. And what happens, and they do this through LA Care Health Plan, which is one of the public plans we have in Los Angeles. And what happens essentially is the Medi-Cal patient gets a Kaiser card. When that patient goes to Kaiser for care, you don't know it's a Medi-Cal patient. They're a Kaiser patient. So Kaiser's going to do the same thing with the exchange. The only difference being is that the benefit structure will be slightly different because of the requirements that the exchange has that are not necessarily the same in the market. Okay? So, but again, next week, because I don't know all the names of all the plans, you'll have it in the packet that you're going to get next week of who are the health plans, you know, in that. Any other questions about that? So this is going to be big. This is as my kids like to say, a BFD, because this is going to change healthcare in California significantly. Just to give you a little bit of background information, not all states decided to do this. Remember I said it was an option? 28 states at last count decided not to do an exchange. California was the first to say yes. 28 states said no. What the law allows for is the federal government then to come in behind the state and put a federal exchange in their state. You know, so it's not like the exchange won't exist, it'll be federally run as opposed to state run. So here's the goal. Now let me add, here's what you got to get. About 1.1 million uninsured people, not on this list, 1.1 million of our 7 million uninsured people will become eligible for Medi-Cal. Okay, so that number's not up here. So add that to each one of these numbers. So in 2014, the exchange is targeting 2.8 million of the 7 million uninsured. And then you add 1.1 million to that and you get a better idea of what the total coverage is expected in year one. Because Medi-Cal is run by the State Department of Health Care Services, not by the exchange. 2015, the 1.1 million Medi-Cal, plus they want to go up to 3.6 million uninsured, and then 4.4 million uninsured in 2016. Those are the goals for coverage. That's a lot of folks. Then we don't know, I think the next chart shows it. We don't know how the small businesses are going to play. But here's an idea that we have. So that's, you know, small businesses, those that employ fewer than 100 people, not 50. Usually, small businesses are usually defined as under 50, but for whatever reason, this was defined as under 100. What you see with the light blue or on each one of these bars is the conversion, meaning how many small businesses are going to send their people to the exchange. They're going to move from straight insurance coverage, group coverage, to exchange coverage. And the first bar is 0 to 49 workers. Up to half of those that currently provide insurance are going to move to the exchange. It's the estimate. 50 to 99, 25% will convert. 100 to 99 to 999. Now remember, that doesn't kick into place until 2017 or 2018. So we're only talking about the first two bars right now. But you see, you get an idea of what's going to happen. Look at the last one, up to 38% conversion total is what we're looking at. So what's going to happen is a lot of employers are going to redirect and channel workers towards the exchange. Why? It may prove to be cheaper. In fact, based on the rates and stuff that we're looking at, that you can see that the exchange is coming over, it will be cheaper. You know, it will be cheaper. And then there's some other reasons that go along with that too. Yes, ma'am.
I ran into someone yesterday who told me who has insurance under their employer right now, and his concern was that it was possible for his premium to become higher. Is that an option that's likely?
It's a different issue. It's a different issue. It has nothing to do with this. But let me tell you, the latest projections from the Society of Actuaries, this is a national society of numbers crunchers, you know, the green eye-shade people, is that Obamacare, and this is where things get tricky, because this is a big experiment, that Obamacare is going to cause health insurance premiums to increase by 32% over the next 10 years. It's either the Congressional Budget Office or the GAO, I can't recall which, who came up with a number of about 13%, 13.2, 13.3%. No one is projecting private insurance costs under Obamacare to go down.
Because they're losing business?
I don't know. Right now I'm reporting to you what the experts are saying. I don't know the reason.
But
I don't know the reason.
Isn't that defeating the purpose of Obamacare?
It doesn't look good for Obamacare with that happening.
It looks good for the ones that it was created for.
What do you mean by that?
Uninsured.
I mean the uninsured. It looks good just for the uninsured.
Yeah, the question is, yeah, the current uninsured, the uninsured are going to win. There's no question about it. Uninsured are going to win. Healthcare cost containment, when you look at premium increases, and what happens with commercial insurers, we're not so sure about. Now, we've had a number of commercial insurers, not a number, we had two, I think, two in the last couple of months, who have abandoned the individual market in California altogether. We're not going to do it anymore. And we're going to see more of them move out. So some insurance companies are going to move out, and others are going to, there's still going to be pressure to increase the rates. Well, if you look at, just hypothesize for a moment, look at what we talked about earlier. What's the incentive to get people to buy the insurance, buy in? It's almost non-existent. If we are not successful in getting people to buy in, adverse selection, only the sick people are going to be motivated to buy insurance. It's going to drive the insurance companies crazy. So they only have two choices. Well, they only have really one choice, and that's increase the rates to cover the cost of treating a pool of sick people. Yeah. But again, I don't know why the Society of Actuaries or how they came up with their number, and I don't know how the Congressional Budget Office came up with its number. But those two authorities are not forecasting decreases pursuant to Obamacare. They are saying specifically, Obamacare is going to cause this to happen.
But didn't the president say the opposite when he spoke a couple of days ago? Didn't he say that in 5 major states, I think he mentioned California and New York, didn't he say, I think Peggy and I did a story about that the same day, saying that premiums were actually going down by like 10%?
Premiums within the exchange will be 10% and greater. 10% and lower. It's a better way to put it that way. Than on the private market. That I don't know what Obama said, but that is true. That is true. You can go online and see what the rates are already. They're going to be lower. You know, but outside of the exchange, no. I don't know where the president. I don't know where the president is getting. I don't know who's prepping the president, so I can't say why they got those numbers.
Theoretically, can't we just abandon our group coverage and go into the exchange?
Well, see, that's part of what people are thinking will happen. That's why I showed you, this is what that conversion chart is about. that,
Individually, can't I just make that decision? I don't.
well, individually you don't buy group coverage. Individually you buy individual coverage.
All right, so get out of my group coverage at work and go into an individual plan. Can I do that?
Well, now hold on a second. If you are working, if you are working and have a group plan and your income is less than 400% of the poverty level, then your employer must give you a voucher to go into the exchange. If you make over 400%, no, you don't have a choice.
So now we're subjected to the increase in premiums that stick it to us every time we have a birthday, every time they feel like it, even though we are under a group coverage system.
Okay. And that's a different issue, but as long as you brought it up, let me go do a digression here to tell you what's out there regarding that. Consumer Watchdog, who brought you Prop 103 on automobile insurance, is sponsoring a ballot initiative for California that'll be on the ballot next year, which will give the insurance commissioner in California the authority to approve rate increases. So arguably, if your viewers vote that in, then there will be more than just a reporting and check and balance system. There will be actual authority where the state can control or regulate rate increases. Pretty much similar to what they're doing in Maryland. The Maryland Commission just slashed insurance premiums in the state of Maryland. Just insurance companies are going nuts, but they slashed them. Right now, all we have in California for rate increases, especially for individuals, is we have the bully pulpit and pressure from the government. And what I mean by that is some of you will recall Blue Cross, Anthem Blue Cross wanted to do a 29% increase on individual policies. This was a while back. And the state screamed and yelled. They didn't have any authority. They couldn't make them. But they screamed and yelled, pressure, and the pressure called for resulted in Blue Cross dialing that back. They fired their CEO. Well, they didn't announce that she was fired for that reason, but everybody knew that, and they did something else. But this ballot initiative will get, but short of that ballot initiative, that situation could still exist in California. Deborah.
How much of these projections from the actuarial group and the Congressional Board of Office can be directly associated with the failure of the individual mandate being fully implemented?
Well, I know.
Is this all essentially a part of that progression that's going to cause that pain to the populace?
Yeah.
And something happens at the individual mandate.
Yeah, the success of the individual mandate was a central piece of the algorithm that they developed to do that analysis. And certain assumptions were made.
So if it goes away, that's what changes all the actuary.
Yeah, right. Yeah, exactly. Okay? Anything else? Nah. Let's see what we got here. Okay, so this is what I kind of put together as a visual to give you an idea of how the landscape is going to look over over time. And each one of these bubbles represent a source of health plan coverage. You may not recognize some of the names like duals. Duals is people who are on both Medicare and Medi-Cal. BHP stands for Basic Health Program, Health Plan. But just look at the larger circles. Medicare, Covered California, which is the exchange, privately insured, and Medi-Cal. This is supposed to be a representation of their share of the market now. So as a result of all that migration from small businesses, enrollment of newly insured people, here's what it looks like in 2014, here's what it looks like in 2017. Notice what happened to Covered California, back to 2014, 2017. 2014, 2017. Covered California's bubble gets larger, privately insured budget gets smaller. 2020, Covered California gets larger still, and privately insured gets even smaller. All of these forces that are listed on here, and I'm not going to go through them all, you can read them at your leisure. All of these forces is going to make it look like that at the end. And after 2020, Covered California is going to be not the 800-pound gorilla, but the 1,000-pound gorilla or 2-ton-pound gorilla in California, simply because of the way the market is changing.
Does that have to do at all with income and the subsidies? I mean, does that mean that large circle of Covered California is represented by people who qualify for the subsidies?
Yeah, if you qualify for a subsidy, you have no choice. You must go to the exchange.
Does that mean that group of people increase by 2020?
It may increase, but what's going to happen more so than that is that other chart where I showed you the business migration, you're going to have more employers getting out of trying to find and setting, using the exchange. Remember, in 2017, there's no cap on the size of the business that can use Covered California. Now the only thing that's really going to keep a lot of these businesses, and this is arguable, this is definitely debatable, the only thing that's going to keep a lot of these businesses from going to Covered California is what the market requires. If Google wants to remain competitive with Microsoft, neither Microsoft nor Google is going to go to the exchange. You get what I'm saying? Yeah. So, because they're packed. Now, later on, I'm not going to do it this week, next week, there's something called a Cadillac tax that's going to be imposed for plan, and this again to help raise some of that $917 billion in savings. A Cadillac tax is going to be placed on those commercial plans outside of the exchange that exceed a certain level. So if Microsoft and Google are giving you gym memberships and all this other kind of stuff, and it's a $26,000 a year plan, right now, no charge, right? No hit. But it's coming, where the government's going to tax you 40%. And we'll talk about that next week. But, so Covered California, so arguably, this is getting closer and closer to something that we call a single payer system. It's getting closer and closer to it. And we think that over time, insurance companies are going to be, this is going to have a demonstrable impact on insurance companies. But there's something else you also need to know, and we're not going to talk about. I don't know if I have that ready on this slide set or not. Hang on a second. Okay, I do have it on here. I'm going to get to it later. But let's do it. Let's go right. Get this up here.
Finish that comment about we think over time insurance companies are going to...
We think insurance companies are going to lose a significant part of their business because physician groups and hospitals are developing these integrated delivery systems and are taking on risk. There's some 28% of the hospitals in California throughout the country, some 28% of the hospitals in the country are looking at developing a health insurance product. They're going to, so if they develop a health insurance product, who are they taking the market from? So we see market share for health plans diminishing over time.
Private government option, so to speak. I mean, private version of government option.
Pretty much, yeah.
This would be a progression of what the groups like Providence has been doing, making the alliances. When they get to enough size, they'll offer some health insurance.
I know I can't violate their confidence. I can't buy. There are a number of systems here in Los Angeles that are either developing or planning to develop a fully Knox-Keene license or limited Knox-Keene license plan. which is a health, Knox-Keene license is what you need to have a health
The
plan.
guys down in Long Beach,
Memorial Care.
they've done,
Yeah, Memorial Care, Providence, and there's some others. Again, I gotta be careful because some of these have not gone public yet, and I can't talk about.
Memorial Care Test.
Yeah, but I'm saying more than Memorial Care. We've got a few here, and quite a few here. And again, I can't get ahead by revealing these strategies. So that's going to have an impact on the private insurance. So this crude chart here attempts to show you where the healthcare delivery system is headed, where the transformation is headed. You know, where we are now, the yellow arrow is episodic, non-integrated care, and it gives you some. You know, we've got the best. I always say we've got the best healthcare delivery system anywhere, except with one small problem. It's not a system. When you think about it, half of the delivery system goes home at 7 o'clock. Half of the delivery system isn't even open on weekends. You know? So we don't have a system yet. Where we're headed with accountable care, which is where this Obamacare is leading us to, and you can read the pieces to that on your own. That's where we want to go. We want to move from paying for transactions, paying for procedures, paying for heads in beds, to paying for wellness and paying for taking care of the patient, paying for the whole kit and caboodle, being responsible for the care of the patient and the health status of the patient. Yes, ma'am.
So you're saying that the problem of a person being sick today, right now, he's dying, he's got strep throat, he's got fevers, and he needs an appointment, but he doesn't have to go to urgent care. And they'll give him an appointment in 2 weeks. I mean, I think everyone knows this.
Okay.
Is that?
Listen to what I'm saying. This is the model design. Again, this is a design. How well it's going to work in a lot of ways still has to be tested. You know, but theoretically, the answer to your question would be yes. Their care is going to be managed in court. Right now, if you call your health plan, let's say you call the nurse advice line. And every health plan has a nurse advice line that's available 24 hours. And you call them up and you say, I think my kid's got strep throat, or my kid's got a sore throat, really bad sore throat. What is that nurse going to tell you to do if it's after 7 o'clock or on the weekends? What? Take them to the emergency room.
Yeah, but you know what's it going to cost you?
No, but that's my point. This system, actually, when we get to the third evolution, this system envisions not having the need to do that. This is a crude chart graph that was put together by a lawyer who's trying to describe healthcare and the evolution of the healthcare delivery system in ways that people can understand it. All right, you've got the blue and the green arrows. These are two components of the healthcare delivery system. Hospitals and specialists on the blue arrow, and you can see what's going on there, and then you get the primary care practitioners on the lower arrow. What's above those are the responsibilities that they have under healthcare reform. The reduction in adverse events, reduction in preventable admissions, all that kind of stuff is the responsibility of hospitals and doctors. Primary care practices, the green stuff underneath there, that's what they're responsible for doing, okay? So the goal is to get to that purple arrow where we improve the management of complex patients and we use, and the use of lower cost settings and providers, the use of those providers who are lower cost increases, and altogether that leads in lower total health care costs. So that's the way they're lining up what Obamacare is wanting to do with health care. So how do we get there? First, with primary care practices, we create a medical home. Medical home, this is the place where you're going to be assigned. You're going to have all of your care coordinated through this medical home. Now, accompanying with this, now keep in mind, we want you to be in a network. We want your care coordinated. You're going to be in a network where health information technology, which is also a big push of Obamacare, has improved. We're going to have the electronic medical record, and we're going to have the shared medical record, meaning everybody in the network will be able to see what's going on with you. So we want you to stay in the network. Now, there is some work being done to develop the shareware where the information can go outside of the network. Some of these systems already exist, but definitely over time, everything's going to be electronic. So we want you in this medical home, okay? So there's a couple of strategies. First, what the federal government is doing, and this is primarily with Medicare, but keep in mind this is a Medicare is a big part of the system. Medicare is bundling certain levels of care together. Instead of paying the doctor and the hospital and the nursing home, what they're going to do is they're going to say, we're going to experiment. You guys get together, post-acute, acute, and primary care. You get together. And we're going to make you responsible for an episode of care that is 3 to 5 days before the patient was hospitalized, all of the hospitalization, and 30 to 60 days of post-acute care. We're going to give you a lump sum of money to cover that entire episode. Take care of the patient, and you figure out how to share that money amongst yourselves. Bundled payment. No longer will you have the doc billing what he or she wants and the hospital billing what they want and so forth. They're going to have. What's the motive? The motive is to get them to work together for the best. Because what happens? They all win if they do the care right and keep the costs down. Because they get to keep the savings. If I'm just play the game, I'm going to give you. I'll throw this number out. $15,000. The idea is, by the way, and there are metrics and there are reporting requirements. You can't cheat on the care. You got to provide the care the patient needs. The whole idea is to do it right and do it efficiently because you may only spend $12,000. Then you guys get to split up the rest. So that's a crude calculation of what. So we have these bundling experiments going on, bundle payment experiments going on now. They're going on now. Accountable care organizations, you've heard of those. ACOs, accountable care organizations. That's the I call it back to the future. Because this is, you may remember back in the 80s, we thought about having something called integrated delivery systems, where the full spectrum of care, cradle to the grave care is provided under one structure. That didn't work so well. Well, we're coming back to it now. We want a fully integrated delivery system. This is what Memorial Care is putting together. This is what Providence is putting together. This is what White Memorial is working on. These are the kinds of things that are going to put together these accountable care organizations that will get a sum of money to take care of everything this patient needs with the network of providers all working together. That is the dream of the future. We've got 250 of these that have been approved in America by the government up to date. Now, we lost a handful that I mentioned earlier, but 250, as of January of this year, 250 of these things were approved and put in place.
Is it interesting that the three examples you just mentioned locally haven't been based in the hospital?
Yeah, it is interesting because one would think that the physician group would be the logical place for this to be heralded.
Especially since the physician groups are more organized, have been
Traditionally more organized. Yeah, well, Deborah, just to repeat so everybody get it. The question was, what I described in my two examples were hospital-centric formation of accountable care organizations. And that's not, you wouldn't think that would be the logical place for that to evolve. You know, the more logical place for that to evolve would be the organized physician groups that we have. The hospital systems and organizations have two things going in their favor. They're threatened more than the physician groups are. They're threatened more. And they've got to make a decision, do we want to be drivers or do we want to be commodities? So they've got motivation. They've got motivation. The second thing that they got is access to capital, which will help them be able to form these things a lot faster and easier than some of the physician groups. That doesn't put the physician, because you do have some physician group sponsored ACOs. I just happen to mention hospital ones because I know them. You also have some that are being led by health plans. The lines are being blended. The lines are being blurred. Health plans are getting into the healthcare delivery system as well. So you're not going to be able to tell anybody. From it, hospitals providing health insurance, health plans providing health care. You know, that's the way this market is moving. And we don't know how it's going to shake out. We just know we got all these people, all these organizations running around trying to do things. Okay? Okay, listen, let's do some Q&A. We're at 11:15. And I'm out of steam, and you want to go home. So I'm going to stop here and pick up next week, but we do have 15 minutes, and so I don't want to cheat you. Although we didn't get through everything on the chart. Are there any questions, any of your last questions? Yes, sir.
Well, my main question is that after all this presentation and all these models that you have shown us, still the demographics, meaning the 800-pound gorilla, it's not taken on account here. I mean, it's still there and it's still growing. And so those projections, I mean, they are assuming that what? Are we going to have an increase in dead people? Or?
No. His question was, these models that I just showed kind of contradict, if not belie, the growth of this 800-pound gorilla called the exchange. And my response to that is, no, it doesn't. Because one is a financing model, and the other one is a delivery system model. And so what the 800-pound gorilla is going to do is finance the health care, and that may include subcontracting to these ACOs, or these organized delivery systems. They're not competing with one another. They're not competing with one another. At least not for the market that is going to be the purview of the exchange. And that market definitely is the subsidized covered people. They will be competing with the exchange for the non-subsidized covered people over 400% of the poverty level, because they'll be able to buy insurance outside of the exchange if they want to. So there will be competition. The argument's going to be, and what's probably going to happen, is the exchange, because of its power and it will be able, and leverage, will be able to offer better rates. And if they can offer better rates, that's going to make them more popular and more useful. So I think the exchange has the upper hand against any other system that might compete with it for the non-subsidized patients. Yes, ma'am.
I came across two numbers for those who may now qualify for Medi-Cal. I believe it's 133 or 138% of poverty line.
Yeah. It's 133 that has been extended to 138 for California. So the law, if you look at the law, it says we go up from 100% to 133. There are special circumstances that allow the federal government to approve up to 138. So that's why you hear both numbers. The law has 133 in it, but reality it's 138 for us. Okay? Yes, sir.
You work for COPE, right?
Yes, sir.
Who is COPE?
Who is COPE?
You know,
COPE Health Solutions.
check your sources.
Go to our website. COPE Health Solutions, we do a number of things. We're a consulting firm, a private consulting firm. We are a nonprofit consulting firm, which is kind of an oxymoron when you think about it. Consulting firm, no, but we are a nonprofit consulting firm because of the mission, our mission and purpose. Our primary goal, our primary mission is to develop the pipeline of the next healthcare delivery system practitioner generation with diversity as a supreme focus. We believe strongly, and the evidence suggests that we're right, we believe strongly that communities ought to have practitioners serving populations that mirror the populations that require services in those communities. So we're trying to beef up. We've got 20,000 alumni, and we have programs that help to develop this. We do have 3,000 students a year that we put through it. And so this is a big deal for us, creating diversity within the delivery of primary care. Then we do run-of-the-mill or bread and butter consulting work too. The strategic planning, helping. Reason why I had to maintain some confidentiality earlier is we're working with one system on developing, one hospital system now on developing their health plan. So I'm not free to name that system. So we do traditional consulting work as well. And then we have something called Global Health Innovations, where we bring in people from other countries to experience healthcare delivery and to witness and to learn from healthcare delivery here in America. So we do a hodgepodge. We do a hodgepodge of things. But some basic garden variety consulting is what we do as well. Except again, we're a not-for-profit agency. Yeah.
Is co-emulating another health system, maybe a Canadian or a European system, to integrate into this country?
Well, it depends on which system you're talking about.
No, I'm not. I'm just asking it.
And ask the question again. I mean,
If you're trying to emulate another health system that functions better, to integrate it into this country.
Is there another model you're looking for?
oh, is it not? No. That's not what we do. We are fully embracing. Our company fully embraces and supports the ACA, and our goal is twofold. Well, actually, it's layered. We want to help hospitals, clinics, and others, and we work mainly with not-for-profit, almost exclusively with not-for-profit organizations. We don't do a lot, very minor, but we're not in the investor-owned side of the market. It's not where we want to play. We work with not-for-profit providers, trying to help them make Obamacare work. That's what so we're not looking to bring in Canada, the Canadian system. We're not looking to bring in a single-payer system. We're not looking to do anything. We're looking to make Obamacare work. That's what our goal is. And the layered piece, step down. Diversity is a big issue for us. And so it's with an emphasis on diversity. Yes, ma'am.
I know that the Covered California organization has a lot of money to spend. I'm wondering, are they spending it on consultants like your group to disseminate the message?
Covered California, well, yes, Covered California is spending, I don't remember exactly what the dollar amount is. I think it's close to $41 million, but I'm not sure the exact amount. I think it's about $41 million on outreach. That's a big part. I mean, they've got that task to get these people starting in October enrolled. And so there's not, and this money, by the way, is coming from the federal government, to do that. By the way, the federal government wants California to be successful. For one reason, we were the first exchange in the country. We stepped up and so they're doing, the federal government is doing everything they can to make Covered California successful. They're throwing money at them, to get it to happen. Yes, sir.
Two questions, if I may. First of all, what do you tell hospitals is the worst thing they face with the ACA coming? And the second thing is, after listening to you today, it still seems like there's a tension between the care that's offered and the cost of getting those down. And sooner or later, one side's going to have to break. In other words, everything's either going to go up or the care is going to go down, or the both gonna go up, or, you know, what are your thoughts about that?
Okay, on the first question, what do we tell hospitals? We tell, it's not just, well, right, what we tell hospitals is this, is what I mentioned earlier. You need to make a decision. Do you want to be a driver in this new market, or do you want to be a passenger? And passenger equates to becoming a commodity. If you want to be a driver, then you need to develop this integrated delivery system. You need to be able to take on risk, which means you got to at least get a limited Knox-Keene license, at least, so you can take on some insurance risk, and we can help you do that. If you want to be a passenger, that means you can be passive and simply offer your product to drivers who will then contract, outsource to you as a passenger. We can help you do that as well because we have what we do Lean and Six Sigma work. We can help you get your expense side down so that then you can be a popular commodity for someone to want to purchase. Your second question, I got lost.
It seems like there still is a tension between the care that's going to be offered and the cost. Trying to maintain
That tension exists. There seems to be a tension between the care and the cost. Care can be offered and the cost. Absolutely. No question about that. That's bigger than Cope Health Solutions, though. It's not something we can cure. All we can do is take what's out there and help these organizations prepare to deal with whatever cards they're dealt. But you're right. You know, I believe there's a crash that's going to come between the demand for health care and the cost for health care. I'm buying what the Society of Actuaries and the Congressional Budget Office are saying. In 2018, the law requires, the ACA requires, the Congressional Budget Office to do a comprehensive analysis and report to Congress on the impact of health care on keeping costs down. We believe, many people that I work with believe, that the Congressional Budget Office's report can be written today. That based on everything that's going on, we're still not going to be able to depress costs as much as is set for and thought about with Obamacare, which is going to make the case for those dominoes falling, leading us towards a single payer system. Well, this system failed. Let's do a Medicare for all like system and control things. So 2017 or 2018, I forgot, is going to be an important year when Congress gets that report. By the way, they'll know before they get the report because every year they're going to be seeing healthcare costs continue to go up. You know, and think about this for a minute, folks. Think about it. Even if all these strategies work, it doesn't take a rocket scientist to figure out this. And this is that the population is expanding and the population is aging. So healthcare costs are going to continue to rise for those two reasons, in the aggregate, for those two reasons alone. There's nothing you can do about that. You know, I could argue philosophically that, you know, we missed our opportunity. And you guys are going to, the Catholics in the room are going to hate me. You know, that lady, Palin. No, Sarah Palin.
I don't think she's Catholic. Is she Catholic?
No, but I'm just saying she referred to some of the activities in the health reform as death panels, creating death panels. Well, here's the deal. You know, 60% of the costs that you're going to spend over your entire lifetime is going to be spent in the last 2 years of your life. 60% over your entire life is in the last 2 years. We don't die very well in this country. We don't conclude. You know, it's only up until last year that more than 50% of the hospitals had palliative care programs. Death is the enemy. Death is the enemy. And I argue that that's the wrong perspective to have. We haven't learned how to deal with that. And so you got a population that's getting old. My mother is 92 years old. And this is a true experience. My mother had a bad knee. I went bone to bone. I didn't know it, but my younger brother's a physician. He's a gastroenterologist. So my younger brother is helping her. And the next thing I do, I get this telephone call. Your mother's in the hospital. I didn't know this. Your mother's scheduled to go to the hospital to have a knee replacement. It's okay, fine. So I want to talk to the surgeon. What are you going to put in her? He's going to put a titanium knee in her. I said, at this time, I said, the woman is 88 years old. Why are you? The titanium knee, that will last 50 years. My mom isn't. But the titanium knee is more expensive. This is the kind of stuff that's got to stop. You know, and dealing with some of the other end-of-life issues. That was an end-of-life issue, but dealing with end-of...
Say that to the physician?
No, I didn't say that. Didn't have that conversation with Mom. You know, but we just don't do this well. We just don't do aging care well. You know, I would argue that. So that's our enemy. That is an anathema. That is a contradiction to reining in healthcare costs. One of the many contradictions to reining in healthcare costs. We're not ready to have that debate or that discussion. Other countries have dealt with that. In Great Britain, as an example, you do not get a renal transplant over the age of 55. You don't get a kidney transplant over the national health system in England will not put a kidney in your butt if you're over the age of 55. See what she said? That's bad, right? Now, here's what you. Let me make it even worse for you. You don't like that. You're not going to like what I'm going to say next. You're not going to like what I'm going to say next. And that is, but if you can afford it, you can buy it and get it. But the government won't. It's a government system. You won't get it. If you have severe cardiovascular disease in Great Britain, there are certain treatment modalities that will not be made available to you unless you clean up your act. In other words, if you're smoking and if you're overweight, we're not going to stent you. You can go somewhere and die. We're not going to, because you got to change your behavior. Lose that weight and stop smoking. We're not going to waste this technology on you. They've had those conversations and made those decisions. That will never happen in America. But there's a price to pay for that not ever happening in America. And that will be, continued cost pressures.
Will it be addressed?
I don't think so. Not in my lifetime. Maybe my son's lifetime, but not in mine. I just don't see us having evolved to that point where we can have that kind of a discussion. All it takes is for one person to do what Sarah Palin did. And we'll talk about comparative effectiveness and the panels that have been put together all she had to say was death panels. All she had to say was death panels. And the minute she said that, it killed the whole discussion. Discussion stopped. That was irresponsible for her to have done, but she killed the discussion.